So next up, we're going to hear from Melissa Chang, one of our nurse practitioners in the cath lab, who's going to be talking to us about in-stent restenosis update and devices. So please join me in welcoming Melissa.
Good morning. My name is Melissa Chang. I'm a nurse practitioner at the Mount Sinai Cardiac Cath Lab. Today I'll be discussing what is in-stent restenosis, update and devices, also known as ISR. I have no relevant financial disclosure. What is ISR? ISR is also known as when the luminum narrowing is greater than 50%. Here you can see there's a blockage in the artery. We deploy a balloon catheter, and the stent is inserted, dilated, then the stent is deployed. And you see ISR occur in the luminal cross-section. Types of ISR. ISR can be defined by its pattern, a classification system that was described by Dr. Roxana Moran, as many of you may know. When ISR is greater than 10 millimeter is class 2, 3, and 4, which is diffuse, and 4 is total occlusion. And when there's focal pattern 1 is when the ISR is less than 10 milliliters. Incidence of in-stent restenosis. Bare metal stents, which is the mainstay of stent before, but had a higher rates of ISR, is rarely used, and it occurs relatively early within the first 6 months. It is reported at about 15% of ISR in the first year. New generations stent, which is drug-eluting stent, has an incidence of 2% in 1 year. And the first generation drug-eluting stent is 13 to 15% at 5 years. Second generation drug-eluting stent is at 5 to 6% at 5 years. Drug-eluting stents has the anti-proliferative drugs such as paclitaxel, which is Taxus, sirolimus, which is Cipher, and second-generation stent includes everolimus, which is Xience, tacrolimus, Onyx, and bioresorbable polymer, which is Synergy. There are 2 review articles of ISR that were published in 2022, which I'll be discussing. First will be a state-of-the-art review, which was published in JACC by Dr. Agustino and the team at the Mount Sinai Heart Hospital. Second will be a state-of-the-art review published in Eurointervention by a European group led by Professor Robert Byrne. There are key anatomical factors, clinical factors, and stent-related and procedural factors that increase the risk of ISR. Firstly, anatomical factors such as calcified lesions, bifurcations, and small vessels. Then there are clinical factors such as diabetes, chronic kidney disease, and anti-proliferative drug resistant. Lastly, stent-related and procedural factors such as bare metal stents, stent underexpansion, and stent fracture. Here is a proposed algorithm for ISR, which we generally follow at the Mount Sinai Hospital. First, you need to identify the mechanism of ISR by intravascular imaging, either with IVUS or OCT. OCT has better image resolution, but may not be suitable in patients with chronic kidney disease. Here is ISR due to underexpansion. In Figure A, OCT was used to visualize ISR, and in Figure B, IVUS was used to assess ISR. Factors favoring use of drug-coated balloon versus drug-eluting stent implantation in ISR. Although it's not available in the United States, like Dr. Sharma said, drug-coated balloon is available in Europe, and we're having trials, ongoing trials, which is the solution trial at the Mount Sinai Hospital. And Dr. Ron Waxman spoke about drug-coated balloon and the benefits yesterday. It was a great talk. Favors in drug-coated balloon is used when ISR with less aggressive patterns of ISR, which is focal with good luminal expansion after balloon dilatation, ISR of bare metal stent, multilayer ISR, patients at high bleeding risk who cannot tolerate DAP. Favors in repeating drug-eluting stent, which includes ISR with more aggressive patterns, such as diffuse or occlusive at high risk of recurrence, ISR of drug-eluting stent, single-layer ISR, presence of a stent-related mechanism, such as stent fracture or stent gap, suboptimal lumen expansion after balloon dilatation. ISR treatment, such as rotational atherectomy, a diamond-coated burr that rotates at high speeds at 140 to 180,000 RPM to ablate ISR and calcium, IVBT, intravascular brachytherapy, localized radioactive radiation to suppress fibroblast proliferation and the neointimal hyperplasia, intravascular lithotripsy, localized pulsatile sonic pressure waves liberating bursts of energy that modify the calcified coronary plaque. So regarding the antithrombotic treatment after PCI for ISR, it can be treated with 3 months of DAP if it's a single angioplasty, whereas drug-eluting stent and IVBT is greater than 1 year of DAP therapy. Here's the second article Professor Robert Byrne highlights in the European Management of ISR. Similar to the first paper, here are some key factors contributing to ISR. Factors to consider when performing ISR: stent factors such as underexpansion, undersizing, fracture gap, stent type, edge restenosis; extra stent factors such as neointimal hyperplasia, neoatherosclerosis, calcification, thrombus, obstruction severity; extra stent factors, multilayer stent, vessel calcification, calcified nodule, vessel size, and residual plaque burden. As you can see in figure A and B, it shows homogeneous severity in neointimal proliferation, which has a sandy beach appearance with the stent shrunk visible on the highlighted with the white arrows, and the ISR is greater than 50%. In figure C, D, demonstrate neoatherosclerosis, and E and F shows thrombus. This slide shows all the trial of evolution treatment over time, which started in 1997 to 2021 with bare metal stent, and now with drug-coated balloon and drug-eluting stent forming the mainstay. On the top left corner, you can see IVBT has more recurrence of ISR compared to drug-eluting stent, but less than angioplasty. On the bottom, you can see drug-eluting stent has better or comparable outcomes to drug-coated balloon. Here is the European algorithm for management of ISR. You start with intravascular imaging, just like us, OCT versus IVUS, to address the mechanical issue, and finally treat with drug-eluting stent or drug-coated balloon. Do's and don'ts with ISR. First, you define the lesion. Do not rely on angiography alone to assess ISR. You do use intravascular imaging to define ISR. Second, you identify contributory factors. Do not stop after identifying one contributory ISR factor. Do assess for multiple contributory factors. Address mechanical issues. Do not treat without first modifying mechanical issues. Do attempt to address all identified mechanical issues. Treat as underlying stent type. Do consider drug-coated balloon in preference to drug-eluting stent for bare metal ISR, and do use drug-eluting stent or DCB for drug-eluting stent ISR. To reiterate the fundamental steps of ISR, first you need to define, then prep, and finally treat. Here are a few nursing considerations: recurrence of angina symptoms. Is the pain similar to your past PCI? Compliance with DAP, such as aspirin and P2Y12 inhibitors. P2Y12 inhibitors such as Brilinta, Effient, and Plavix. Can the patient afford newer generation of P2Y12, Effient, and Brilinta? If not, then switch to Plavix. Are they a PRU responder? PRU responder is usually less than 230. Lifestyle modification, a heart-healthy diet, smoking cessation, and exercise. Thank you.